I keep seeing glycemic index charts treated like moral rankings for food. Watermelon gets side eye, some candy looks less dramatic than expected, and then everyone says glycemic load fixes it. What are these numbers actually measuring?
Glycemic index is usually tested by giving people a food portion containing a fixed amount of available carbohydrate, often 50 grams, then measuring blood glucose over about 2 hours. The area under that curve is compared with glucose or white bread. So the index asks, gram for gram of available carbohydrate, how fast and high does this food tend to push glucose? After you eat starch or sugar, digestion releases glucose and other sugars in the gut. Glucose is absorbed into blood, insulin helps move and store it, and the liver moderates what appears between meals. A rapid, large rise is not automatically dangerous in a healthy person, but repeated high post-meal exposure matters more when insulin secretion or insulin sensitivity is impaired.
So, if the lab feeds equal carbohydrate, that explains the weird fruit examples. But in the kitchen, I do not eat 50 grams of available carb from every food. Is glycemic load basically the index multiplied by the portion?
Yes, with a big caution. Glycemic load is an estimate, not a glucose prophecy. It is usually calculated as GI times grams of available carbohydrate divided by 100. That makes it practical, because a small portion of a high GI food may have a lower load than a large portion of a medium GI food. But it still assumes the table value fits your product, cooking method, and body.
Most charts act like I eat foods alone under fluorescent lights. What happens when the same starch comes with beans, oil, vegetables, yogurt, or eggs? Does the original GI still tell me anything?
A nice example comes from a small randomized crossover breakfast study in 25 children and teens with type 1 diabetes. A high GI, high-load breakfast produced higher early glucose excursions. Adding 10 grams of protein to that high GI breakfast lowered the average 3-hour glucose compared with a high GI breakfast alone, and a lower GI option also improved time and range. That does not make protein a cure. It shows meal design can change the curve. For anyone using insulin, sulfonylureas, or other glucose-lowering medication, this is where the boundary matters. Lower GI choices can reduce a post-meal rise, but they do not replace carbohydrate counting, prescribed dosing, glucose monitoring, or a clinician's plan. If someone changes breakfast patterns and starts seeing lows or unexpected highs, the answer is not more chart reading. It is medication-aware adjustment with their care team.
That makes me wonder about continuous glucose monitors. People post screenshots proving oatmeal is terrible for them or rice is fine. Are those personal curves better evidence than a GI table, or can sensors mislead too?
Both can help if you know their weak spots. In a small randomized beverage trial, carbohydrate amount and glycemic index influence peak glucose, and CGM tracked blood glucose overall. But agreement worsened during rapid declines. Interstitial glucose can trail blood because it is measuring the fluid around cells, not directly inside the bloodstream. So use repeated patterns, similar meals, and symptoms, not one dramatic screenshot. The best fit is someone trying to reduce post-meal glucose swings without turning food into arithmetic punishment. People with diabetes or prediabetes, some people with insulin resistance, and possibly women with PCOS as part of a broader dietary strategy. In a post-systematic review, multiple diet approaches, including low GI or low-load diets, often improved weight, waist measures, insulin sensitivity, hormones, or menstrual regularity, but designs were heterogeneous, so it is not a single proven formula.
Short-term glucose curves are persuasive because you can see them. But if someone asks whether low GI prevents heart disease, cancer, or diabetes over years, is the evidence as clean as the 2-hour graphs?
No, and that is where marketing gets too confident. In people with type 2 diabetes, a large review found moderate certainty evidence for Mediterranean diet adherence and lower cardiovascular disease, but no clear association for glycemic index or load with cardiovascular outcomes. A colorectal cancer meta-analysis found only a marginal higher risk signal for high GI, with no definitive dose response. And in preview, after rapid weight loss. A moderate protein, moderate GI diet outperformed high protein, low GI for prediabetes remission.
If labels do not list GI, what should I actually do at the grocery store? Am I looking for total carbohydrate, fiber, added sugars, serving size, or just choosing less processed starches?
Make it boring enough to learn from. Keep the meal size similar, swap one variable, and repeat it. Try oats cut differently. Rice cooled and reheated versus freshly cooked. Beans replacing part of rice, or adding protein to a breakfast that spikes you. Judge success by a lower peak, less fatigue, if that is a consistent symptom, better time and range if you use CGM, and whether the meal is still nutritious and livable.
When should someone stop chasing lower numbers? Is there a point where glycemic load tracking becomes the wrong priority, especially if they're pregnant, recovering from illness, or already restricting food?
My bottom line is use glycemic index to understand carbohydrate speed. Use glycemic load to respect portion size, and use your actual meals to decide whether the idea helps. The most defensible swaps are usually simple. More intact grains or legumes, more fiber-rich plants, less sugary drink exposure, and protein or mixed food structure when a meal spikes you. Treat the numbers as a compass, not a courtroom verdict on a food.